So, good morning to everybody. Welcome to all the attendees and guest speaker to this 20 Sarcoma educational session in the framework of IMPERAS Project. Many of the attendees know what is the IMPERAS Project, but just to remind that this is a project, the main goal is to review of sarcoma, central review sarcoma in Spain. Thank you for joining us to this educational session. We encourage to all participants to submit questions or remarks by using the chat box. Sorry, please mute your micro during the presentation to avoid interruption. Sorry, I have to silence these microphones. Please mute your microphone, please, during the presentation to avoid interruptions. For protecting educational purpose, this session will be recorded just for you to know. Now it's my pleasure to introduce our first guest speaker for today's session. First speaker is Dr. Marta Sbaraglia from Pathological Anatomy Azienda Ospedaliera in Padua, Italy.
Yes,
Padua. It's Padua.
Yeah.
Right. She has many contributions in bone and soft tissue sarcoma fields. You know her surely, and has been author for a liposarcoma charter from the WHO Blue Books of Bone and Soft Tissue. So, yes. Marta, many thanks for your time. I'm pretty sure we will enjoy your presentation. Please share your screen when you wish, and thank you.
Thank you, Dr. Machado, for inviting me. Now I try to share this screen. Okay. 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 Do you see the slides?
Yes.
Perfect. Okay, good morning, everyone, and thank you, Dr. Machado, for inviting me to this meeting. The case I present is about a 70-year-old female with a previous history of breast cancer, treated with surgery, chemotherapy, and radiotherapy. In 2015, due to epistaxis and nasal congestion, the patient was studied with MRI that revealed a sinonosal mass measuring 5 centimeters, and subsequently she underwent endoscopic resection of the mass. Histologically, the tumor was composed of monomorphic spindle cells organized in medium to long fascicles, and as you can see here, growing into submucosa. There were some mitotic figures and no necrosis. Bone infiltration was present, how shown in this slide, and the cellularity was quite high. Areas of classic herringbone pattern is easy to identify, like here, and the stroma was predominantly collagenous. Furthermore, areas of hyalinization of vascular wall and the stroma were observed, and there were also hypocellular myxoid areas with epithelial features. Based on morphology, we ask for a small panel of immuno, and here I report the more interesting results. And as you can see, neoplastic cells showed a patchy positivity for S100, and neoplastic cell express smooth muscle actin and desmin. Furthermore, scattered cells express myogenin corresponding to focal rhabdomyoblastic differentiation. There was also a diffuse and weak expression of EMA, a single cells showing expression for cytokeratin. In conclusion, based on the morphological and immunophenotypic features, our final diagnosis was of B phenotypic sinonasal sarcoma. In order to confirm the diagnosis, we perform a target NGS using the Archer fusion plex sarcoma V2 that revealed, according to our diagnosis, the presence of PAX3 mammal3 fusion transcript. But what do we know about this tumor? B phenotypic sinonasal sarcoma was first described in 2012 by Lewis with the label of low-grade sinonasal sarcoma with neural and myogenic features. B phenotypic sinonasal sarcoma is a low-grade sarcoma. This tumor demonstrates a predilection for middle-aged women and most often arises within the superior sinonasal tract, particularly in ethmoid sinus and upper nasal cavity. Clinically, is characterized by local recurrences, but not distant metastases have been reported. The same group subsequently renamed the entity as B phenotypic sinonasal sarcoma, and they discovered in almost 80% of cases the presence of PAX3 mammal3 fusion transcript, and in almost all cases tested, the rearrangement of PAX3 gene, thus becoming the diagnostic hallmark of these tumors. More recently, it has been confirmed that 90% of cases show a PAX3 rearrangement. Different fusion partners of PAX3 other than mammal3 have been reported, such as WWTR1, FOXO1, or NCOA2 and 1, and FOXO6. Some fusion like PAX3 FOXO1 and PAX3 NCOA1 or 2 are also observed in alveolar rhabdomyosarcoma, an aggressive sarcoma showing a typical round cell morphology. The involvement of PAX3 in these tumors may be demonstrated by different molecular techniques, but also through less expensive and time-consuming means like immunohistochemistry. In fact, as a result of PAX3 fusion, the neoplastic cells show an overexpression of PAX3 protein that may be detected by immunohistochemistry. Dr. Vicky Zhou from Boston has demonstrated that the PAX3 antibody is very useful in distinguishing B phenotypic sinonasal sarcoma from his morphologic mimickers. Characteristic morphologic features include high cellular infiltrative proliferation of uniform blunt spindle cells with scant matrix, APC vascular pattern, and proliferation of intrabenign surface epithelium, here showing a squamous metaplasia. Nuclear atypia is moderate and mitotic activity usually is very low. Sometimes areas of rhabdomyoblastic differentiation may be observed morphologically, and this is highlighted by the presence of large cells with bright eosinophilic cytoplasm, prominent nuclei, and focal cross striation. Immunohistochemically, the tumor appears B phenotypic with the expression of both neural and myogenic markers. In fact, the tumor cells express multifocally both S100 and smooth muscle actin. The area of rhabdomyoblastic differentiation is positive for both desmin and myogenin. It's important to remember that neoplastic cells may also show nuclear expression for beta-catenin and focally stain for pancytokeratin and EMA, whereas SOX10 is usually negative. Differential diagnosis is rather broad. It includes benign and malignant mesenchymal tumors. The main entities in the differential diagnosis are listed on the slides. Now I show some examples. First is schwannoma. Schwannoma of the sinonasal tract is usually a circumscribed lesion that shows a more fibrillary stroma, hyalinization of a vessel's wall, and neoplastic cells show a strong and diffuse immunostain for S100 and SOX10, and the expression and lack the expression of myogenic markers. Solidly fibrous tumor is a fibroblastic tumor characterized by prominent branching, thin-walled, dilated vasculature, so-called hemangioparasitic pattern. And this tumor usually lacks myogenic markers and shows an expression of CD34. And due to the presence of NAB2 STAT6 fusion, almost all cases show the expression of STAT6 that represent a hallmark for these tumors. Spindle cell sclerosing rhabdomyosarcoma is a type of rhabdomyosarcoma with fascicular spindle cells, eosclerosing morphology, occurs mostly in the head and neck region and may enter in the differential diagnosis with the biphenotypic sinonasal sarcoma, but already this type of tumor usually is characterized by more atypia and higher mitotic index. And usually spindle cell rhabdomyosarcoma shows a diffuse positivity for desmin, MIF4, and MyoG1. For sure, we have to consider synovial sarcoma, which is a malignant high-grade monomorphic spindle cell tumor characterized by variable expression of epithelial markers, and it's variably associated with the SYT gene rearrangements that now I show here may be detected other than molecular analysis with a simple immunotest. In fact, recent specific SS18 SSX antibody has been validated as molecular surrogate, showing a high specificity and high sensitivity for diagnosis of synovial sarcoma. It works both in monophasic and biphasic variant of synovial sarcoma. Again, malignant peripheral nerve sheath tumor is a high-grade malignant tumor, often associated with NF1 syndrome. The tumors are characterized by variable cellularity, perivascular accentuation of neoplastic cells, nuclear atypia, and high mitotic index. Features that usually are not present in biphenotypic sinonasal sarcoma, that is a low-grade tumor. Furthermore, MPNST are usually negative for neural markers, it's very important, and up to 70% of high-grade MPNST show the loss of H3K27 methylation. MPNST, like biphenotypic sinonasal sarcoma, may show rhabdomyoblastic differentiation, but always in a background of high-grade malignancy that is usually not observed in biphenotypic sinonasal sarcoma. But going back to our case, the patient suffered suspicious of relapse in 2022, for which she underwent a new biopsy. This is the histology of the new biopsy, and to our surprise, the biopsy revealed a high-grade sarcoma with rhabdoid features. Neoplastic cells were larger and epithelioid instead a spindle, with abundant eosinophilic cytoplasm, macronucleoli, and severe atypia. There were large foci of necrosis, and mitotic index was extremely high. Immunophenotypically, other than a focal expression of S100 and a smooth muscle actin, the neoplastic cells showed a diffuse expression for desmin and a multifocal positivity for MIF4. Molecular analysis identified again the presence of PAX3 MAMEL3 fusion, which confirmed the relationship with the previous diagnosed spindle cell low-grade tumor. We signed off the case with the diagnosis of relates of biphenotypic sinonasal sarcoma transforming into high-grade sarcoma. Very recently, a couple of papers have been reported in which a sarcomatous transformation of biphenotypic sinonasal sarcoma have been described, like in this paper. In this table are summarized the clinical pathological features of biphenotypic sinonasal sarcoma cases with high-grade progression that are published until now. In one case, the progression occurred after 15 years after the first diagnosis. In the remaining two cases, the progression was observed at the initial diagnosis. Like the case reported, our case also shows the presence of PAX3 MAMEL3 fusion and the expression of rhabdomyoblastic differentiation. In conclusion, biphenotypic sinonasal sarcoma is a tumor typical of middle-aged women. It appears to be unique of superior sinonasal tract. Histologically, it is composed of high cellular uniform spindle cells proliferation, showing an infiltrative growth pattern and associated with the entrapped hyperplastic surface type epithelium. The tumor is usually correlated to PAX3 gene rearrangement, and clinically is characterized by local recurrences, and no distant metastases have been reported until now. But as I showed today, few cases shown high-grade transformation. Thank you for your attention.
Well, thank you very much, Marta, for this very interesting case. I have 2 or 3 questions for you. Do you feel confident with this PAX3 antibody for diagnosing this entity, or you will be more confident with genetic confirmation? This is my first question.
Yeah, I showed the paper and the antibody, but in my practice, I don't use the antibody because I'm lucky. I have the Archer panel. The biphenotypic sinonasal sarcoma is very rare tumor. So the cases that we have seen in these last years that I see, I tested with molecular analysis. And very important that this is a typical dual immunophenotype with expression of both neural and myogenic markers. Quindi, this feature with monomorphic spindle cell morphology, low-grade feature, I test with the molecular for the PAX3 rearrangements.
Yeah. My second question is that this tumor may remind in some way the AWS PAX-1 case of Hsuan-Ying Sarcoma, as described by the group of Dr. Michal. That's a biphenotypic tumor. I don't know if in sinonasal location would be possible this diagnosis. This is my second question.
Sorry, can you repeat, because I understand the use of MAIG1.
Yeah, no. I guess that the differential diagnosis with the AWS PAX-1 fusion tumor may be some way difficult in because this biphenotype expression.
Okay.
So
in this case, the molecular analysis is, of course, the the only way to separate.
Yeah, and my last question, do you think there is another second driver, molecular alteration, that promotes this transformation to high-grade sarcoma in this case?
Yeah, I performed the Archer panel. That this panel see only the fusion. There is a 63 gene, but we didn't do a extensive profilation. So we can do this, but now I don't know if there is other molecular driver for this progression.
Okay. Dr. Michal, do you have any comment, question?
Yes, I have. Dr. Sbaraglia, thank you very much. It was a beautiful case. I must say I was smiling here because we reported this paper on high-grade transformation. It's like 2-3 weeks ago, I think. And it's like 3 months. My friend Anders Meyer, who is the first author, contacted me with similar case that you have.
Yeah.
I must smile that sometimes these extremely rare things occur in about the same time, because even the other 2 cases that we included in our review of the literature, they were published within the last 1 year. It's quite a coincidence because the tumor is around for 10 or 11 years, or maybe even more, and nobody has ever reported high-grade transformation, and now within 1 year there are 4 cases already. It'd be great if you could publish this your case maybe as a letter to our paper or something like that, because it's so rare. It would be useful.
Yeah.
And I just have one comment regarding the skeletal muscle markers in this tumor. I think we found it more useful, and also in the literature they showed MyoD1 is much better than myogenin, and also PAX7 stains much better the biphenotypic sinonasal sarcoma cells than myogenin, which is usually focal or negative. And regarding Dr. Machado's question about the PET-Z1 sarcomas, EWSR1 PET-Z1 sarcomas, I am not aware of a case in the sinonasal area. I think only the closest area was like the muscles on the back of the neck, but not in the sinonasal area. I'm not aware of a case there.
Thank you.
Okay. Professor John Barr, any question, remark?
A very nice case.
Isidro, ¿me oyes?
Yes.
Thank you. Sorry. Can I say something? Yeah. Well, just Marta, thank you, because the case is very, very nice. And I would like to share the experience in our lab, because we had some years ago a similar case, but the high-grade rhabdomyosarcoma was a small cell rhabdomyosarcoma, mimicking an alveolar rhabdomyosarcoma. And the thing is that when we did retrospectively the Archer panel, the fusion it has was a PAX3 FOXO1A. I'm sure that it was not a rhabdomyosarcoma from the first time, and it showed the same translocation, all the samples, because it was a tumor that was relapsing during around 15 years, only locally, no metastasis. And the tumor was most of the times a spindle cell lesion, sharing S100 and desmin positivity. But in the last relapse appeared this small cell area showing rhabdomyoblastic differentiation. And I think I haven't seen cases like this in the papers you showed, and I think it can expand the experience.
Marta, do you have a question in the chat box?
No, I didn't. But NTRK antibody in mesenchymal tumor is not so specific, so it's not impossible that I do pan-Trk in this type of tumor, or we can see also some positivity. In my experience, pan-Trk antibody is not so specific in mesenchymal tumor, in particular when there is a myogenic differentiation, neural differentiation. So in this case, we have the both combination. So I'm not sure it's very useful test for NTRK. But in the new Archer panel, there is also NTRK gene. So if the tumor should have the NTRK rearrangement, the panel should be detected.
Okay, Marta, thank you for your time and for your presentation.
Thank you.
We continue to our second speaker is Dr. Hsuan-Ying Huang. I hope to pronounce well, Professor and Director of the Department of Pathology, Kaohsiung Memorial Hospital and Shenyang University College of Medicine, Taiwan. He's a very well-recognized international expert in sarcoma, has many contributions in international journal, was the responsible author of myxofibrous sarcoma in the WH Blue Book's classification of the soft tissue tumor. Thank you, Professor Huang, for your time and for your presentation. And you may share your screen when you wish.
Can everybody see my slides?
Yes.
Yeah, okay. I'm very grateful to Professor Machado and dear colleagues. Good morning. It's my enormous pleasure and honor to receive the invitation from Professor Machado to join this educational session. I would like to present a very interesting translocation associated sarcoma, although different from the previous one, also occurring in the sinonasal tract. This 43-year-old female presented with nasal obstruction and a broad tinge discharge for approximately 1 month before seeking medical advice. On the head and neck CT scan demonstrated an infiltrative lesion of soft tissue density, extensively involving the right nasal cavity, as well as the frontal ethmoid and mesentery sinuses with a multifocal calcification. This patient received functional endoscopic sinus surgery to remove the tumor fragments from both the right nasal cavity and ethmoid sinus in a piecemeal manner, as you can see here. Microscopically, the right nasal part was hypercellular, with a spotty calcification in the more fibrotic stroma at a low power. Is composed of vague bundles of spindle to oval cells with irregular nuclear control and sort of a coarse chromatin. The case-fine portion showed deposition of osseous matrix in a less-like manner and with focal mineralization. The right ethmoid part is more hemorrhagic with cystic dilatation at a low power, but extensively infiltrates the surrounding sinonasal mucosal tissue, minor salivary glands, and also submucosal stroma with intact overlying the epithelium. Fascicular growth is less conspicuous in this part. Rather, solid sheets of undifferentiated round cell form the predominant pattern with easily identifiable nucleoli. The mitotic count was up to 6 per 10 haplofields with tumor necrosis focally. Similarly, we also found focal deposition of mineralizing osteoid matrix arranged in interconnected woven bones. Along with the produced matrix, the tumor cells also showed permeative growth in the intertrabecular spaces surrounded by host bone trabecula. In summary, this case was composed of a hypercellular undifferentiated round or ovoid to spindle cells with high NC ratio, prominent nucleoli, and occasional mitosis, forming solid sheets or vague bundles in the architectural pattern with focal geographic necrosis and deposition of delicate osteoids. The diagnostic consideration of a matrix producing neoplasm in the sinonasal tract with round and spindle histology are quite broad, for which we have to first exclude more common entities, including both translocation associated and unrelated ones. So at this point, I would like to have Professor Machado to show my first question on the screen, or perhaps I could do it on my own. Let me try first. Can everybody see my first question? Which of the following fusion-driven mesenchymal neoplasm is least frequent in the sinonasal region? A. Alvarado. B. Mesenchymal chondrosa. C. synovial sarcoma. D. salivary fibrous tumor. And E. ossifying fibromyxoid tumor. My answer is ossifying fibromyxoid tumor. Actually, in this particular sinonasal region, there is no well documented such case with molecular confirmation. Okay. Yeah, I think most of the audience agree with my answer. So let's go on to proceed the remaining slide. Ewing sarcoma extremely rarely occurs in the sinonasal tract. The vast majority lack the deposition of osseous matrix. They mostly exhibit solid sheets of uniform round cells with scanty or sort of a clear cytoplasm. Notably, a sinonasal adamantinoma like the Ewing sarcoma has ever been reported to exhibit metaplastic bone among nests of rounded or epithelial cells, as you can see on the left, as well as the presence of osteofibrous dysplasia-like matrix set in edematous or more fibrotic stroma. However, our case is entirely negative for both CD99 and NKS 2.2, not fitting the typical immunoprofile of Ewing sarcoma. Second, mesenchymal chondrosarcoma is not rare in the craniofacial bone, particularly the jawbone, with involvement of the adjacent sinuses, especially the mesentery sinus. Histologically is biphasic with islands of well-differentiated hyaline cartilage scattered among compact sheets of uniform round cell interspersed with stacked home blood vessels. Once in a while, these chondroid components can be very scarce. Instead, the eosinophilic matrix resembling osteoid may predominate. In this scenario, the detection of the pathognomonic H1 UNCO-A2 fusion is quite helpful in arriving at the correct diagnosis. However, our case is negative for these gene fusion, according to RNA sequencing results to be demonstrated later. Although our case shows a strong SHTP2 nuclear labeling, indicative of osteoblastic phenotype. Small cell osteogenic sarcoma is extremely rare in the sinonasal area, and is a diagnosis of exclusion from other round cell mimics with unique genetic aberration, which I would like to go into details. Next, I would like to go over several spindle cell neoplasms to be differentiated, which may have a more or less osseous matrix. First, head and neck solitary fibrous tumor most commonly affect the orbit, followed by the nasal cavity with or without the involvement of peronasal sinuses. Specifically, solitary fibrous tumor with heterologous osteosarcomatous differentiation has never been well documented in the sinonasal area, unlike its somatic soft tissue counterpart, with these osseous matrix embedded among malignant cell. Moreover, our case is negative for STAR6 by immunostaining, as well as negative for NAP2 STAR6 fusion by RNA sequencing. Although phosphaturic mesenchymal tumor is overall an ultra-rare tumor entity, it's not uncommon to occur in the sinonasal tract, with accounting for almost half of the head and neck cases. Not necessarily always. Histologically, PMT may show these characteristic grungy calcification, as you can see on the left. And the head and neck cases tend to more frequently undergo adipocytic metaplasia. Less often, prominent osteoblastic differentiation can be observed in a minor subset of PMT, and even more rarely, sarcoma just histology are either in compact herringbone-like bundles or in storiform architectural patterns can occur in a minor subset of PMT, for which we call it malignant phosphaturic mesenchymal tumor. We also consider the possibility of heterologous MP and ST with osseous differentiation, while our tumor is negative for S100 and retained for the trimethylated histone 3 lysine 27, are arguing against the possibility of MP and ST. Our focal calcification and/or ossification can be observed in around a quarter of synovial sarcoma across all anatomic sites. When abundant, these matrix may make ossified synovial sarcoma look like the osteogenic sarcoma. Our head and neck synovial sarcoma only account for 7% of all cases. Among these, our sinonasal cases are exceptionally rare and limited to isolated reports, with the majority involving the paranasal sinus. However, our case is negative for SS18 SS fusion protein, and also negative for SS18 gene rearrangement by fish. But a recent study by Japanese group described a novel genetic subset of or synovial sarcoma harboring either EWSR1 or NN1 gene fused to SS1 as alternative fusion. In this scenario, the fusion protein cannot be detected by immunohistochemistry. To delve into these possibility, we perform EWSR1 fish and indeed found a gene rearrangement. But very intriguingly, the tumor cell are entirely negative for TOE1, or a finding very unusual for synovial sarcoma. We also consider the possibility of a heterologous myoepithelial neoplasm with osseous and/or chondroid components from the perspectives of both soft tissue and solid grain primaries. As for the former, soft tissue myoepithelial tumors may harbor EWSR1 rearrangement in around 50% of cases, while the salivary gland counterpart only has 5% of cases being EWSR1 fused, with the majority being driven by POH1 related fusion. Our case is only focally reactive to GFAP on the left, but negative for all epithelial markers, including EMA. So this case only shows a partial immunophenotypic overlap with myoepithelial differentiation. And this case is diffusely positive for these non-specific CD56. Let's look at the second question. Professor Machado, could you please show the second question on the screen on behalf of me? Yeah, in the sinonasal region, which is of the following mesenchymal tumor with matrix production is not driven by a pathognomonic gene fusion. A, PMT, B, mesenchymal control sarcoma, C, MPNST, D, SFT, and E also finds synovial sarcoma. My question is MPNST, which is driven by PRC2 inactivated mutation, CDKN2A loss, and N1 are in elevation. Okay, let's go ahead. There are also two recently characterized EWSR1 fused sinonasal sarcoma was being mentioned. The first one, EWSR1 band 2, is composed of a low-grade atypical spindle cell with some interspersed stack-home blood. It also shows diffusion SATP2 nuclear reactivity, but weaker in intensity as compared to our case. The lower one, EWSR1 core CA2, may harbor both undifferentiated round cells in solid sheets or compact sheets of elongated spindle cell, varying in proportion from case to case. They resolve this diagnostic conundrum. RNA sequencing was performed and unexpectedly detected an inference fusion between EWSR1 exon 15 and the core CA2 exon 2, as cross-validated by RT-PCR coupled with some good sequencing. So the final diagnosis goes to an undifferentiated round and spindle cell sarcoma with a novel EWSR1 core CA2 fusion with previously unreported bone formation. At 4 months postoperatively, MRI study shows no evidence of tumor recurrence. Currently, the patient is undergoing adjuvant proton radiotherapy. Let's move toward discussion. EWSR1 core CA2 is a novel gene fusion recently reported to define a group of sinonasal sarcoma with round and spindle cell histology, which is still waiting for formal pagination. The estimated prevalence rate of these novel tumor types is supposed to be very low, namely 5 out of more than 10,000 cases as analyzed by RNA sequencing, and accounting for only fewer than 1% of primary sinonasal sarcomas. Our core CA2 mapped to 11q23.1, similar to its core CA1 counterpart, was first discovered by Jiwa's study as a colorectal cancer risk gene locus. It has 5 confirmed protein isoforms of variable length, while gene fusions involving core CA2 are not well characterized, with only a rare core CA2 mutation detected in a minor subset of melanoma. Core CA2 is proposed to be a putative tumor suppressor with downregulated expression in the colorectal mucosa to increase cancer risk. In addition, core CA2 also confers an immunity-related anti-tumor function. The 5 reported cases all occurring in the sinonasal region included 3 females and 2 males aged between 23 and 57 years. Histologically, typical spindle or rounded cell were disposed into nondescript fascicle or solid sheets with a variable mitotic activity. As you can see here in this example, the tumor cells are rounded with slightly irregular nuclear contour and focal spindling. Only the overlying epithelium is reactive to cytokeratin. The tumor cells are entirely inactive and do not show the typical membranous reactivity of CD99, characteristic of Ewing sarcoma. Epithelial-like organoid arrangement was observed in only 1 case, exhibiting these cribriform architecture and focal peritoneal invasion, hence mimicking morphologically a low-grade salivary gland type carcinoma. It shows only the focal cytokeratin positivity, but diffuse and strong CD56 expression. Notably, unlike today's case, neither osseous nor chondroid matrix was described in any case of this series. Collectively, these novel type of tumor is negative for all lineage-specific markers. And the breakpoints of core CA2 were relatively constant, occurring either at the 5' end of exon 2 or within intron 1. However, those of EWSR1 tend to occur across C-terminal exons, including our case, and unlike exon 7 or 8, more commonly seen in Ewing sarcoma. At the last follow-up, 2 patients remain disease-free at almost 2 years, and 3 patients developed local recurrences, with 1 of them experiencing distant mass to the rib. On the last slide, with an acronym, NOS Alarm Plus, is a reminder to help you remember important diagnostic consideration of lung and spinal cell neoplasm occurring in the sinonasal tract, ranging from various types of carcinoma, sarcoma, and even melanoma and teratocastinosarcoma. Thank you for your attention. I'm pleased to take any question. Thank you.
Thank you very much, Dr. Professor Huang, for this very, very interesting case. I have never been, of course, seen any of these cases, but so my question is that maybe the differential diagnosis, do you think that myoepithelial carcinoma could be related with this entity? Because this spindle cell morphology, polyphenotypic, AWS is a translocation in some cases, myoepithelial carcinoma. I mean that in sinonasal location, maybe myoepithelial carcinoma could be the most important differential diagnosis with this entity that you have already presented, because Ewing sarcoma could be staying positive for NKs 2.2 and strong CD99 knowing the same way that this tumor is staining. What do you think about?
Because this case is negative for both CD99 and NKS 2.2, so the possibility of typical Ewing sarcoma is very remote. I have to admit that. But as you can see in my slides, there is other melanoma like the Ewing sarcomas with metaplasia. So I think it's not entirely irrelevant in these diagnostic consideration. As for myoepithelial neoplasm, admittedly, somatic soft tissue cases has more frequent EWSR1 rearrangement are identical to our case, and around 10% of such cases may exhibit or matrix production. Yeah, but as I can recall, there was one paper on the EWSR1 arrangement in cervical tumors from Czech. They described around nearly 5% of cases of cervical neoplasms are harboring the EWSR1 rearrangement. Yeah, if I can recall it correctly. So although I know cervical cases most often show PAH1 or HMGA2 rearrangement.
Okay. Further question, Dr. Michal, Professor Jambar, Marta, any of the attendees? You are free to do question or remark.
I'd have a brief comment. Thank you, Dr. Huang, for this wonderful case. Again, I have to smile because we are currently writing up a series on, or small series on these tumors. We have now 2 cases of this EWSR1 COLCA2 tumors. One is in the sinonasal area as well, as usual. It doesn't stain for anything and looks like an uncharacteristic spindle cell sarcoma. But the other case is actually in the chest wall, so outside of the typical sinonasal location. And it looks like a neuroendocrine carcinoma. It even stains for cytokeratins. There's a patchy cytokeratin and EMA expression. Also patchy cyanotophysin and chromogranin expression. And it's indistinguishable from neuroendocrine carcinoma, but the patient doesn't have any primary tumor anywhere else. So it's most likely primary neuroendocrine carcinoma of the thoracic wall with this fusion. And I know a group from United States, they are writing up another small series, and they have a case in the thigh with this fusion, which looked somewhat distantly, remotely similar to extraskeletal myxoid chondrosarcoma. So there might be a little bit different group little bit different looking group located in extrasinonasal locations with this fusion. We will see what comes out. So thank you very much for this case. I was really interested to hear about this. Thank you.
You are very welcome. So you think that these gene fusions may not stringently define a group of sarcoma, and tumors harboring these gene fusion can have expanding morphologic spectrum and immunophenotypic expression.
Yes, I think so.
Is this your point?
Yes, that's what I want to say. Yeah.
Thank you.
Thank you.
Yes, Dr. Huang. In fact, the presence of osteogenesis within the Ewing sarcomas has been already described not in the sinus nasal area, but in other sides of the bone, in the legs mainly. Well, it is clear that it's a new entity with this new translocation, but from the practical point of view, the differential diagnosis with one microcellular osteogenic sarcoma could be also taken into consideration, because if not an immunohistochemistry or a molecular biology analysis is performed, what will be your diagnosis?
Yeah, if our molecular diagnosis is not performed, I will call it sinonasal or osteogenic sarcoma, period.
Yes.
Yeah, because no immunohistochemic markers are specific enough to define its differentiation, except for the presence of very characteristic tumoral osteoids. Yeah, and osteogenic sarcoma occurring in the head and neck region, including paranasal sinus and associated bones, are not that uncommon. So, take out our molecular diagnostic, I will call it our osteogenic sarcoma.
So you think that if we see one Ewing-like sarcoma with osteogenesis, we should always perform the molecular biology analysis with COCA and EWS1, even if they're outside the sinus nasal area.
Yes, outside the sinonasal areas, if I found that a small brown cell malignancy with deposition of O6 and Ewing like histology, definitely I would perform EWS1 fish to confirm its or exclude its Ewing sarcoma. And then if EWS1 is negative, I would like to tend to call it our small cell ODS.
Very nice case. Congratulations.
Thank you for your comments and question. Any other question from the audience? Thank you. Thank you for the invitation, Professor Machado.
You're muted.
Sorry. Thank you for your participation and for your willingness to present this case in our session, because we know that in Taiwan is 8 hours ahead, or 7, no? 7, right? 7 hours ahead. So thank you for this participation. We continue with our last speaker, is Dr. Michal from the Department of Pathology, Charles University, Faculty of Medicine, Czech Republic, and Bioptical Laboratory, Czech Republic. He also a very well-recognized international expert in sarcoma. He has many contributions in International Journal of Sarcomas, for instance, in Reunión ETS sarcomas and other sarcoma topics. So thank you, Dr. Michal, for your time and for your willingness to participate in this session. So you may share your screen and start your presentation when you wish.
Okay, thank you, Dr. Machado. Also, thank you for the invitation. This is a wonderful session. I really enjoy it. So can you see my screen? Okay, excellent.
Yes.
Excellent.
Yes.
I must say I find it a little bit hard to present my case now after these two wonderful presentations, but I'll try at least partially to match the quality of the previous two cases. The case I'm presenting is a case of a 40-year-old male with an intramuscular tumor of the thigh. This picture, I wanted to illustrate the perfect circumscription of this tumor, which is quite typical for these lesions. Also, you can appreciate on this low magnification that it's quite highly cellular neoplasm. On this another picture, you can probably note these conspicuous histiocytic aggregates, which are another constant feature of these neoplasms.
Dr. Michal, sorry, we cannot see your presentation moving. So can you put it in full screen? Try to choose again.
So is it moving now?
Yes, it's okay.
Perfect. Okay, so I'll get back. My first slide. Low power magnification showing the very good circumscription of the tumor and pretty high cellularity. On the other slide, I wanted to show this conspicuous histiocytic aggregates, which are very common in these tumors and are very helpful for the first on the first impression to help you think about this lesion. Also, calcifications are a very common finding in these tumors. You can see it's predominantly spindle cell tumor with dispersed chronic inflammatory cells, mainly lymphocytes and plasma cells, which you can also see on this higher magnification, many lymphocytes all around the tumor. When we look at the neoplastic cells, they are predominantly spindled, or somewhere you can also see epithelioid cells, and many of them have this hyperchromatic, a little bit bizarre looking nuclei, which maybe give you the first impression you are looking at something which might be biologically aggressive. Sometimes it's not very conspicuous at the first sight, but when you look closely, you can find also these rhabdoid looking cells, which might be more prominent in other areas of the tumor, such as here. This looks like a strap cell of rhabdomyosarcoma, while this cell here looks like a rhabdoid cell. However, when you look at the higher power, at the highest power at these cells, they constantly lack cross striations. Also, you can note on this picture these multiple foamy histiocytes, which are admixed with the neoplastic cells. Another section, this H&E has different color. It looks like from a different tumor, but it's just an old H&E from the same case. It's just different area of the tumor. Again, you can see these strap-like cells and rhabdomyoblast-like cells. At this section, there are numerous rhabdomyoblast-like cells as well, lacking cross striations. Also, what is important, and I would say very important to diagnose these tumors, when you look at the neoplastic cells, you barely ever see a mitosis. This tumor is almost amitotic. It doesn't have usually more than one mitosis. Usually it's a problem to find any mitosis at all. These tumors are constantly desmin positive, usually diffusely desmin positive. Again, when we go on a higher power, you can see this strong cytoplasmic staining for desmin, and maybe you can, especially in this example here, you can note this bubbly characteristic of the cytoplasm of the neoplastic cells, which is not present in all cases, but when it is present, it's quite helpful. I'm not aware of seeing something like this in other tumors. Here, another example, bubbly cytoplasm, bubbly positivity in the cytoplasm. What can be helpful as well is if you look at this slide, only about 50% of the cells are positive for desmin, the rest is negative. And in contrast, when you stain CD163, the other half of the cells stains, which shows you nicely that there is a huge amount of admixed histiocytes and macrophages, which you don't really appreciate on the H&E slide. It's visible only in the IHC staining for histiocytic markers. It's also quite helpful diagnostically. Another markers that are usually positive are MyoD1 and PAX7. PAX7 is like a more recent more recently introduced skeletal muscle markers. I really like it. It's excellent, especially for some tumors. And this is one of those that stain much better with PAX7 than with myogenin. Myogenin is often negative in these tumors or only very focally positive. It's most likely because myogenin is expressed later during the skeletal muscle development, while PAX7 and MyoD1 are expressed earlier in the embryological process during skeletal muscle differentiation. And it shows that this tumor probably has like immature skeletal muscle phenotype. Might also explain why you don't see the cross striations in the tumor cells. Another somewhat helpful immunohistochemical marker is ordinary Ki67, which I know many pathologists, many soft tissue pathologists don't like at all to use, but this is the only scenario where I find this marker helpful in soft tissue pathology, to use it for tumors that look aggressive maybe on H&E, but if you get almost zero Ki67 staining, it shows you that it actually might not be as aggressive as it looks on H&E. So almost zero Ki67 expression, in my experience, usually is present in not aggressive tumors. But I will be happy to hear your comments and interested to hear your comments about this. I know many of my friends that they hate Ki67 and will never do it on soft tissue lesions. So the diagnosis, according to the current WHO classification, is inflammatory leiomyosarcoma, but this name is gonna almost certainly change in the next classification to inflammatory rhabdomyoblastic tumor. It's a term proposed by Dr. Andrew Fulp, so we can be pretty certain it's gonna make it to the next WHO. So now I would like to share with you a brief history of this entity, which is quite amazing, I think. It was first mentioned already in 1995 by Dr. Fletcher's group, and they chose the designation inflammatory leiomyosarcoma because it has a partially similar morphological and immunohistochemical features with conventional leiomyosarcoma. Back then in 1995, there was the more specific skeletal muscle markers such as MyoD1, myogenin were either not available or not widely available. So they had only desmin and SMA, and because this tumor is desmin positive and often also SMA positive, they thought it stains like leiomyosarcoma. However, quite recently it has been shown this tumor has significant clinical pathological differences compared to conventional leiomyosarcoma, both clinical, morphological, as well as immunohistochemical differences. So the name leiomyosarcoma will be changed, as I mentioned, to inflammatory rhabdomyoblastic tumor. Since 1995, since the first series on this tumor, there was for 22 years almost nothing written on this entity, except for this, I think it was a case report by Dr. Paula Dalsin, and she reported the first study on molecular background of these tumors. They did a karyotype study and showed these tumors have a very specific molecular background because these tumors show massive reduction in the number of chromosomes to a point of near haploidization. So near haploid karyotype, that means that instead of having 46 or approximately 46 chromosomes, because not all tumors have 46 chromosomes, but this one has only 25 to 28 chromosomes in many cases. But what is interesting, there is always retention of chromosomes 5 and 22, as is seen here, and sometimes of chromosomes 18, 20, and 21. There are also some cases where you see this pattern, but then the whole genome or the whole chromosome number gets doubled, but they still come from the same parent. It's like only the mother derived chromosomes get doubled, or the father derived chromosomes get doubled. So the patient has close to 46 chromosomes, but most of them come from the same parent, except for 5 and 22, which in this situation are in 4 copies, present in 4 copies. So as I mentioned, since 1995, apart from this paper, this report on the molecular background, for 22 years there was pretty much nothing on these tumors, and only in 2017 there was this wonderful, very sophisticated study from Dr. Mertens' group. Dr. Mertens is probably the best molecular biologist investigating sarcomas, and besides other very complicated molecular analysis, they did also gene expression profiling, which revealed a very high expression of genes which take part in the development of skeletal muscle. So genes like MyoD1, MyoG, or PAX7 were highly expressed. However, this study did not attempt to verify these findings on a protein level using immunohistochemistry. At about the same time, Dr. Folk's group published this excellent paper on tumors that, to my eyes, looked at the time identical to inflammatory leiomyosarcomas. They had the same clinical pathological features. They had a predilection for males, predilection for intramuscular locations, especially on the lower extremity, and the same expression of desmin. But they called it histiocyte-rich rhabdomyoblastic tumor. It was also about the same time with my group here in Plzen, we were studying a series of inflammatory leiomyosarcomas. And based on these two publications I just mentioned, this one histiocyte-rich rhabdomyoblastic tumors and this paper by Dr. Mertens, we immediately went to the lab and stained them for PAX7, MyoD1, and myogenin, and found a pretty constant expression of skeletal muscle markers. Almost all cases we had in our series expressed skeletal muscle markers. So we quickly published this paper, which was the first one to show that inflammatory leiomyosarcomas actually stain for skeletal muscle markers immunohistochemically. And eventually, Dr. Falk got together his series of histiocyte-rich rhabdomyoblastic tumors and Dr. Mertens' so-called inflammatory leiomyosarcomas. He stained the tumors of Dr. Mertens for skeletal muscle markers, came back positive, and he did genome-wide copy number analysis of his so-called histiocyte-rich rhabdomyoblastic tumors, and most of them showed the same molecular background as inflammatory leiomyosarcomas. So he concluded that these tumors are actually the same, and suggested the name inflammatory rhabdomyoblastic tumor. So when I try to summarize the salient clinical pathological findings, so from clinical perspective, this tumor occurs usually around 40 years of age on average, but can occur in a wide age range, but usually not, or I don't know about a case in children. The earliest case I found was 18 years old patient. These tumors have distinct male predilection and also tend to present as intramuscular lesions, especially on lower extremity. Thigh is by far the most common location for about half of the cases, but they can also occur on the trunk, on the neck, and rarely elsewhere, such as in the lungs or retroperitoneum. The tumors in the lungs are probably a little bit different. I'll touch on this a little bit later. And there are a few well-described cases in the retroperitoneum where they most likely arise from the iliopsoas muscle. On follow-up, most of the cases reported have behaved very indolently, but the situation is changing a little bit. I'll touch on this at the end as well. Morphologically, these tumors are very well circumscribed in most cases. In some areas, you can see a focal infiltration sometimes, but in general, there is a very well circumscription, often with a pseudocapsule. Architecturally, there is nothing really striking. Mostly the cells grow in a haphazard fashion. Sometimes you can see short and thin fascicles. From the cytological point of view, you can see mostly spindled, but in parts epithelioid or rhabdoid cells, with some of which have moderate to severe atypia. It's pretty constantly present, this hyperchromatic nuclei with weird shapes. So that's pretty common or pretty constant feature of these tumors. Rhabdoid cells are usually present, but they constantly lack cross striations. You can always see dispersed lymphocytes, almost always histiocytic aggregates, aggregates of foam histiocytes, which are very conspicuous. And especially on histiocytic markers staining, you can appreciate the huge amount of spindled histiocytes admixed with the tumor cells. Sometimes at the edge of the tumor, you can also find lymphoid aggregates. Tooth-type giant cells can be present, and sometimes they can form a predominant component of the tumor, so it looks like a giant cell tumor in the minority of cases. What is very important, mitotic activity in the classical examples should be extremely low, usually less than 1 mitosis per 10 high power fields, and necrosis is usually absent and focal at most. Immunohistochemically, there is an expression of skeletal muscle markers, especially MyoD1 and PAX7. Myogenin can be only focal or negative. Very commonly, you can see patchy expression of smooth muscle actin. Always you see diffuse CD163 or CD68 or other histiocytic marker expression. And I find useful to do MIB1 or Ki67 staining, which is usually less than 5%. Regarding the molecular genetic background, I showed the typical situation, so the near haploid karyotype with retained heterozygosity for chromosomes 5 and 22. But it's important to note that this molecular background does not have to be present in all cases. I would say, I think 20 to 30% of cases lack this classical molecular background. What is interesting, many cases have NF1 gene mutation, and I know about 2 studies. One is from we are taking part of one of them that are showing these tumors are often present in patients with neurofibromatosis type 1, which is of course in accordance with finding of NF1 gene mutation. So here's the paper where I think Dr. Huang took part as well. Yes, it reported that the pulmonary examples of so-called inflammatory leiomyosarcoma seem to be a distinct subset. They seem to be different from inflammatory rhabdomyoblastic tumor because they don't see convincing rhabdomyoblastic differentiation, and they have diploid genomes, so they lack the near haploid karyotype. So that's a very interesting topic which needs more studies as well to show the same results. Differential diagnosis depends, of course, on the location where the tumor occurs. If it's in the retroperitoneum, the #1 differential is, in my opinion, inflammatory dedifferentiated liposarcoma with a myogenic differentiation. When it occurs elsewhere, you can also think about, or in other locations, you can also consider in IMT, inflammatory myofibroblastic tumor. Of course, you can consider it in the retroperitoneum as well, or follicular dendritic cell sarcoma. But all these 3 potential differential diagnoses are quite easily resolvable with immunohistochemistry. So the most important and difficult differential is pleomorphic and spindle cell rhabdomyosarcoma. The most useful morphological features are the infiltrative growth in most cases of rhabdomyosarcoma, and as well as the high mitotic activity, which is present in most pleomorphic and spindle cell rhabdomyosarcomas. Also, you can look at the proliferative activity, which is usually very high in rhabdomyosarcomas as well. Also, these pleomorphic and spindle cell rhabdomyosarcomas usually don't contain a prominent lymphocytic and histiocytic component. For differentiation from spindle cell rhabdomyosarcoma, you can obviously also use molecular genetics. You can test for MyoD1 mutation or for the fusion-associated spindle cell rhabdomyosarcomas, which will definitely help you a lot. The problem is that inflammatory rhabdomyoblastic tumor has been convincingly shown to be able to transform into what seems to be a distinct subset of rhabdomyosarcoma. The first report was again by Dr. Folk's group, who published this. Basically, it was a letter to the editor to Modern Pathology, where he showed tumor with typical features of inflammatory rhabdomyoblastic tumor, lacking mitotic activity, with well circumscription, etc., and having the same near haploid molecular background with retention of chromosome 5, 20, and 22, transforming into a full-blown rhabdomyosarcoma. In this case, it would be called probably pleomorphic rhabdomyosarcoma. And very, very recently, literally last week or this week, this paper in Modern Pathology came out, again from Dr. Folt's group, where they published 6 cases of inflammatory rhabdomyoblastic tumor transforming into rhabdomyosarcoma. So all the 6 cases had areas of classic inflammatory rhabdomyoblastic tumor, which transformed into a little bit different looking types of rhabdomyosarcoma, which I will show on the next slide. In any case, there stays, even in this subgroup with high-grade transformation, you can still see the male predominance. These tumors seem to occur a decade later than typical inflammatory rhabdomyoblastic tumors, but they still occur in pretty much the same locations, so intramuscular locations of the lower extremity especially. You can see on the follow-up status that there were 5 metastases out of 6 cases. 1 patient died and 4 others are alive with tumor. So it's obviously a very aggressive tumor, metastasizing mostly to the lung. And regarding the morphology, all the tumors transformed into either what could be called rhabdomyosarcoma, composed of monomorphic rhabdomyoblasts with diminished histiocytes, which was it seemed pretty useful. They did a Desmin staining for this area. It was almost all cells were Desmin positive, whereas if they did CD163 histiocytic marker, it was almost negative or only very focally positive. So in the case of so-called overgrowth of monomorphic rhabdomyoblasts, you don't see by far so many histiocytes as in the conventional inflammatory rhabdomyoblastic tumor. You can also see more mitotic activity, although not very high, usually 1 to 2 mitoses per 10 high power fields in these areas. The other possible form of transformation of inflammatory rhabdomyoblastic tumor is depicted on the middle picture. So transformation into a spindle cell sarcoma with occasional presence of rhabdomyoblasts, which is shown here. I'm sorry, the pictures are a little bit blurry. It's not high quality. And the third situation is transformation into a spindle cell sarcoma, high-grade spindle cell sarcoma with multiple mitoses, very high mitotic activity and necrosis. So these are 3 possible ways of transformation of this tumor. So I would say the story of this tumor continues. I find the history of this entity really exciting, and it's still not finished. Even after more than a quarter of century, we still don't know everything about this tumor. So I hope you enjoyed it at least a little bit as much as I do. And this is my favorite entity in soft tissues. So thank you for your attention.
Thank you, Dr. Michal, for this very nice presentation. This is really a very interesting tumor. I don't know if low-grade inflammatory myogenic tumor would be very appropriate for this tumor, because maybe inflammatory rhabdomyoblastic tumor could be confused for the clinician, because usually pathology ones speaking about rhabdomyoblastic, does this mean for the clinician high grade is a carcinosarcoma with rhabdomyoblastic? So I think the low-grade inflammatory myogenic tumor, I like this terminology. Consider, of course, that this may transform to high-grade tumor. And I agree with you that maybe case 67 is a very good tool for confirm, because as far as I know, in high-grade rhabdomyosarcoma, Ki67 usually is higher, completely different with this tumor. I don't know your opinion and the opinion for the other speaker and the audience.
I have a question. My question is, have you, because Volpe described that some of these tumors had loss of NF1, and but no cases, well, no or few cases, I think that no cases have been described since now in NF1 patients. Have you any experience with that?
Yes, I'm participating on a study where there are, I think, 2 patients with neurofibromatosis. I think one case has been published by, I don't know if it was Dr. Fopp or somebody else, from neurofibromatosis patient. And I think some Spanish group, maybe somebody is in the audience, some Spanish group is presenting.
Yeah, it's me.
Okay, great.
Bueno, me and Tulio.
I'm looking forward to your presentation on your chat.
Yeah, we have only 3 cases and 2 are in neurofibromatosis patients. So because of that, I'm surprised.
I'll be there. I'll be there.
Okay, see you in the USCAP.
Is there any further question? Sylvia, I know you have a lot of experience with this tumor. Could you provide some information or some question? Sylvia Baguette. Professor John Ball, Marta, anyone who may want to
actually we do come across inflammatory rhabdomyoblastic tumors occurring in an neurofibromatosis type 1 patient, which was published together with another ordinary cases together in correspondence to modern pathology in reply to our Dr. Angel Forbes' original paper. Yeah, we have one case occurring in one patient.
Okay, thank you.
Interesting. I'm curious how the WHO is going to cope with this tumor, because now we have the low-grade, the conventional inflammatory rhabdomyoblastic tumor, and the high-grade rhabdomyosarcoma arising from inflammatory rhabdomyoblastic tumor. So I don't know if they're going to form, because there's in WHO you have only benign skeletal muscle tumors and fully malignant skeletal muscle tumors. So I think Dr. Forbes mentioned something like they will have to form a new category of like intermediate or skeletal muscle tumors with intermediate malignancy, where they're gonna put this. So I'm really curious how are they going to do that. We don't hear you, Dr. Machado.
Any further question, remarks, opinion? So is there a remark in the meeting in the chat box that this meeting should be in the morning? It had no sense to do in the afternoon. Yes, we agree, but unfortunately in the morning everybody working usually, and that is difficult to do. But we will try. We usually do the meeting in the afternoon when there is a speaker for Latin America and from the USA. And in this case that we have a speaker from Asia or from Japan, we do the meeting in the afternoon. That is the usual way that we are doing. Any further question?
I think somebody mentioned here in the chat that they should use Fulp and Fletcher tumor for this entity, which is that would be the easiest, of course.
Sorry, it was me. I just couldn't help it.
Yeah, it's a good suggestion, but I think there are so many Fulp and Fletcher tumors that might be mixed up. Yeah.
Okay, thanks for the nice presentation.
Thank you. We use the term Fulp tumor for superficial CD34 fibroblastic tumor. That we even code it in our database Fulp tumor. So you would get mixed up.
Okay, thank you very much to all the guest speaker and the attendees. I think that this was a very, very nice session today. We're hoping to see you in next section. As usually, we will send the link for the next session. The next session is in March, and there will be speakers from Brazil, Mexico, and probably USA. So hoping to see you there, and many thanks for your time and for your presentation. See you soon. Bye-bye.
Thank you.
Thank you.
Bye-bye. Thank you for everybody.
Okay.
Thank you. Bye-bye.
Bye-bye.